I'm Doug Nelson, and you're listening to the ABMP Podcast, a podcast that speaks to the massage and bodywork community. Today, I'd like to explore a topic that all of us in the practice of clinical massage therapy face, the return of symptoms after initial improvement. There is nothing like sitting in front of a client who comes in and says, well, it was better after our last session, but now it's just kind of back to the way it was. And you can see the disappointment in your face. And I know that kind of sickening and feeling in my own heart of like, whoa, so now what? Well, that's what I want to explore today is now what? How do we respond to that? And where do we go from there? And believe me, this happens. This is not infrequent, at least in my practice. And so I'm hoping that it's the same in yours. And I'd like to go over some of the explanations that might explain this and also give you a different perspective and maybe some different ways to approach this. First, I think it's important to acknowledge that improvement actually happened. And first, you should celebrate that. In my own practice, kind of my worst outcome is nothing. When a client comes back and says, I don't know, it wasn't worse, it wasn't bad, I just didn't notice anything. That means I'm so lost that I didn't even, it didn't even irritate it because I wasn't anywhere close to what, quote, quote, it is. So that means I need to reevaluate everything and start completely over. But even if I've irritated it, then at least I've discovered, quote, quote, it, and I dealt with it in the wrong way. So now it's a strategy thing. I just need to approach it in a totally different way. But at least I know some idea of, again, quote, quote, where it is. Before I go over the 4 possible scenarios, I think there's one other thing that needs to be addressed. And that is, are we sure there's been no change? Because, and I bet this has happened to you too. I'll ask the person, so really, everything is really back to the same? Yeah, I'm just right back to where I was. And then I'll say, well, yeah, it's really too bad. Are you still taking the Advil? And you see that look on their face of, Advil? No, I haven't taken that for a while. Like, really? Because before we worked last time, here's how much you told me you were taking. And then you see that, oh, yeah, I guess, well, that's different. And what about activity level? So you just told me that you cleaned the garage yesterday, worked on the attic, and then waxed the car. What I have in my notes is before your first session that just like did something simple like doing the dishes was killing your back. And so now you're telling me you can clean the attic, wax the car, and it's like the same? And then you see that look in their face of, oh. Because really when they just shift back to, quote, quote, their normal activity level, guess what? It feels, who knew, normal. That's the advantage of our human nervous system. We are incredibly adaptable. That can cloud the issue in cases like this because this like cessation of symptoms or a slight improvement now feels normal, where the pain to them before felt, guess what? Normal. So which normal are we actually talking about here? I think that's where some notes, some guidelines, some survey instruments, meaning some questions like the Oswestry score and low back pain or something like that. Just a small set of questions so that you have some reference point to go back to them and say, well, is this still true? Because if it's not, then it's not the same. But there are many different instruments for different conditions. And some of them, you want something that's as efficient as possible. Everybody hates, the 87 questions, but, something with just 6, 7, maybe up to 12 questions, that might not be a bad thing to do just to have a reference point to bring back to them. So now let's go over the possibilities. And I'm thinking of 4 different ones. I'm probably leaving out several. So there are probably things I haven't thought about, but here are 4 that come to mind when I think about the return of symptoms. First off, are we sure that what we're dealing with is mechanical pain? And let's go over the definition of mechanical pain. Mechanical pain is pain that is made better or worse with movement or position. So you ask a client, is there something you can do to make this discomfort more, some movement that you can do that irritates it, some movement you can do that makes it better, a position you can put yourself in that reduces the discomfort? What things can you do to create a change in your experience? Honestly, if they can't think of anything, that's probably a red flag, because there are several things that clearly, and many of them are not good, that are unaffected by movement or position. The bottom line is that it's a non-mechanical pain. And that's probably something that if they haven't seen their physician, it's probably a really good idea for them to do that, just to rule it out. So first start with that. And that's important because my expertise is in treating mechanical pain. That also means it's my bias and my blind spot, right? Where I will probably overestimate the number of times that the source of their discomfort is mechanical, musculoskeletal. So I always have to protect for that, be careful about my own expertise becoming also a bias that may not serve my client well. So that's the first thing. And, because there can be other reasons. For instance, there also can be joint issues, like they're having low back pain and, is there some sort of joint issue that's in response to this? Is there a restriction in their hip that might also play into this? And so there could be arthritic changes in their hip. Visceral issues are really interesting because as the nociceptive input from some problem in the viscera goes into the dorsal horn, that is also shared with a musculoskeletal component. So you could actually have something that's presenting as both discomfort and sensitivity when you press on it in the muscle that's actually really coming from the viscera. But again, there would be associated symptoms that might be also part of the equation that wouldn't be true if it was just musculoskeletal. So these are all things to consider. Second, in terms of the reasons for the return of symptoms, I think is the one that at least most therapists think of first. And that is the client doing something that is re-stimulating this area? Oh boy, that can be really difficult to play the detective to figure that out. Because, at least in my experience, if you try to pose that to the client, invariably what you hear is, no, I can't think of anything that I do that would do that. Well, that's, that's not really helpful. But here's how I deal with that. And I would suggest that you give this a try. I tell people, okay, the muscle that we're dealing with is this. And here's what that muscle does. And then I demonstrate to them so that, do you do anything with this kind of movement? And invariably the answer is no. It's like, well, I know, but just pay attention. So many times people have come back and only to say, you know what? I never thought about this before, but I do this particular thing all the time. And that's exactly what you were mentioning, but I would have never noticed that. So don't tell them about a specific activity, because how would you know this, right? You can't be with them on a 24/7 basis. But describe the potential irritants based on the anatomy you're treating. You might have a better time with that. Thirdly, another reason for the return of symptoms is just that you're not getting to the source of the problem. We really need to think in terms of systems. Thinking in terms of muscular systems is a really, really important kind of sea change for me, because no muscle does what it does independently. All muscles are part of systems. And so in any system, if you have one part that is doing too much, you have another part that's doing too little. And oftentimes it's the thing that's doing too much is the thing that's complaining. But the reason it's complaining is because something else is like lazy and doing nothing. So there are so many examples of these kinds of things. Earlier, I mentioned, for instance, the hip and the low back. Well, this is a common reason for low back pain. If you have a restriction in hip range of motion, then you're going to force the low back to to accommodate for that, to compensate for that. And over time, the low back is going to lose its sense of humor about this because it's doing too much. So just addressing the low back is never really going to solve the problem. It will certainly make a little difference in the beginning, right, of addressing it. But of course, it's going to come back because the reason underneath it is still there. Whatever technique you use, you're still looking at the thing that is overplaying because something else is not doing its job. So this is where a really deep understanding of functional anatomy comes in, because you need to know who those other players might be. And that's why we study, that's why we do all the work. If it was only looking at the presenting symptom, it's not that hard to discover those things. What's really hard is not just discovering that, but understanding the context that created it. That is infinitely deeper and richer for us as therapists, and something that clients really often don't see. Fourth, and this is the one I think is the most common reason for return of symptoms, and that is an incorrect frequency of treatment. Most often, you're just not seeing them soon enough. Imagine this scenario. I'm a cello student, so I'm practicing an etude. Let's say I'm doing the prelude of the first cello suite, which is a very difficult piece for the cello, but it's also a skill-building piece. So I practice it and I work on it for 25 minutes, and it sounds terrible in the beginning, and then now it's actually at least decent by the time I finish my practice session. So then, 10 days later, I pick up the cello again, and guess what? All the skills that I obtained after the first practice session have all left, and now I'm right back to where I was in the beginning. And in 25 minutes, I get back to kind of that improvement again. And then I pick it up 10 days to 2 weeks later, and I'm right back to ground zero again. Imagine how frustrated I would be. I would think, I have a really bad cello. I am not capable of playing the cello. Or who even likes this? I mean, it's just a study in frustration. I don't even understand why people do this. All of it's incorrect if I would have just changed the frequency. Why is that not true in our field with massage? Because it's also true in exercise. It's also true in medication. It's also true in just about any skill acquisition you can think of. Frequency matters. But oftentimes for many of us, we get into this default mode of whatever that is, but is that relevant to this case? Is that relevant to solving problems? Or are we using kind of the default mode that we got for more general approaches and not altering it when we're dealing with very specific things? I think that is certainly the case. And that was a hurdle for me in my own practice years ago of just feeling comfortable telling people, you know what? I think I should see you sooner. So when is sooner? Ideally, in my mind, if their symptoms have improved, at the point where symptoms start to come back up again, that's where I want to see them again, so that we don't lose everything that we gain. And that might be shorter sessions, done more frequently, but just to front load that activity to gain some momentum. And in another podcast, I really want to explore frequency and duration in much more in depth. But for right now, let me just say that I think that is one of the most common reasons where therapists struggle to be successful is frequency issues. And sadly, there's just not a lot to go on in our own profession. So I have been practicing for 45 years, something like that. So I have some history with clients to go on. But what is a new therapist who's just starting their practice? What are they supposed to look at in terms of a guideline? And that's really what the research literature and these kinds of things is. It's not a prescription. It's not, you must do this. It is simply a guideline for therapists to say, here's a framework around which we can play inside of. And I've heard people push back against this idea, well, everybody is really different. Well, everybody's really different playing the cello, and everybody's different with medications, and everybody's different with exercise. But when you have a robust literature, you have some guideline to at least have a starting point, a reference point to begin with. Otherwise, it's just up in the air and it's just random. And clients deserve better than random, and therapists deserve better than random. We need some sort of framework. And it's my sincere hope that someday in the research literature, we have 15 studies for each condition around which we can get some consensus of this is probably the right frequency and the right dosage. In the end, if we just summarize this, clients need to pay attention both to their daily activities and also maybe a little journal, a little something, so they have agency in the process, so they're paying attention to anything that they might do that plays a role in this, and also celebrating any improvement that they're having by monitoring their activity levels. And again, that gives them agency. They really have to realize it's a partnership thing. It's not like you come and I do my thing, and this is not a fix-it kind of thing. This is a partnership kind of thing. And then also, we need to widen the search and think much more about systems rather than simply symptoms. And then we begin playing with frequency and dosage. And I think I want to give you the courage, the license to really explore that. Start varying those things and see for each condition, for each person, what is an appropriate and most effective approach. So I wish you to be relentless. I wish you to be curious and willing to explore new approaches, because in the end, as Marcel Proust said, the real voyage of discovery consists not in seeing new landscapes, but in seeing with new eyes. So thank you again for the important work that you do. It's needed now more than ever. And I'll see you down the road on the learning journey, all right? I'll see you at the next stop. Thanks, everyone.